We'll be dealing with oral and maxillofacial pathology. So what branch does oral and maxillofacial pathology ascribe to? Basically, it is a branch of dentistry which deals with the identification of the diseases, the nature of the diseases, and the causation of the disease. Okay, oral pathology is a branch which deals with the identification of the disease, the diagnosis of the disease. Okay, so you as a oral pathologist, first you'll just diagnose the disease based on the clinical signs, clinical observations, clinical symptoms. Then you'll just give a provisional diagnosis. Then after investigating the case, after carrying out certain prescribed biological tests, biochemical tests, any examinations, any further radiological examinations needed, after all that, you'll just give a final diagnosis for the case. Basically, oral and maxillofacial pathology, it is a science that investigates the causes of the disease, the etiology for the occurrence of the disease process, the identification of the disease process, and the side effects or the observed effects of the particular disease process. So whenever you get a case, you have to just initially take a history of the disease. Okay, the history of the disease, the clinical symptoms of the disease which the patient gave you. Then you have to just observe for the clinical signs of the disease. Then based on that, you have to conclude a provisional diagnosis. Okay, then based on your provisional diagnosis, you have to just prescribe the patients any further investigations needed, either a radiological examination, either the biopsy, either a cytology, exfoliative cytology, or any histological tissue. The tissue is taken and it is sent for histological examination. So any histological examinations are carried out, only then the final diagnosis is given. Okay, so that's all the procedure how you carry out a case. So the oral and maxillofacial pathology basically deals with research activity, because after knowing that that is a particular disease, the pathologist tries to find the nature of the disease, the causation of the disease, what was the etiologic factor behind the disease. So the oral and maxillofacial pathology, the branch, it involves extensive research of the disease, along with that the diagnosis of all the oral and maxillofacial diseases affecting the hard tissue, diseases affecting the soft tissue, the clinical diagnosis. Basically, hard tissues are diagnosed based on their appearance, based on the symptoms, based on the radiological examinations, whereas soft tissue diagnosis is based on the clinical observations. Specifically on the clinical observations, you have to identify the size, the location of the lesion, the form of the lesion, the appearance of the lesion. Okay, the appearance of the disease, how it is occurring, what color it is, what is the size of the lesion, and whether it is focal or diffuse, and whether it is attached to the epithelium or it is just freely mobile. So what is the content of the fluid, whether it is fluid filled or whether there is no fluid in it. So the clinical observation is of crucial value in diagnosing the soft tissue lesion specifically. Okay, so once you have identified the lesion, once you have located the lesion, then you have to send it for further investigations. Okay, like for the hard tissue lesions, radiographic examination of that particular area will be essential. And for the soft tissue lesions, especially exfoliative cytology and biopsy are of diagnostic value to identify the nature of the lesion, the nature of the disease, to identify the disease process. Okay, then suppose if a complete excision of the lesion is carried out, then it is sent for microscopic or histological examination, where staining procedures are carried out and the characteristic histologic feature is seen, so that particular disease can be identified by its histologic features. And any further blood test or biological test that may be required, may be carried out. And because the maximum of the oral facial diseases, if suppose they are benign, they had to be put on follow-up for many long years to rule out any associated development of malignancy in that particular cases. Okay, many pre-malignant conditions are there, pre-malignant lesions are there. These are put under follow-up. So because you have to just rule out any further development of malignancy in future. And suppose a benign lesion has been excised and it is sent for histopathological examination, and it is of very diagnostic value that few of the malignant changes are seen. So you have to put the patient under follow-up for that reason. So oral and maxillofacial pathologists deal with the follow-up of the cases, deal with the management of the particular patients, and routine histochemical techniques for staining that particular tissue whichever is excised, so as to rule out and locate the exact lesion whatever is responsible for causing the disease. Okay, to locate the neoplasm, to know which neoplasm it is, to identify the disease, to identify the nature of the disease, the oral and maxillofacial pathologist helps in all these procedures. Okay, so we'll see what are the common lesions. Okay, we know once you identify a case, once you have taken the history of the patient and you are taking the clinical observations. Okay, as I've told you, for the hard tissue lesions, just the appearance, the location and the radiographic examination will be of diagnostic value. Whereas for the soft tissue lesions, you have to identify the lesion by clinical observation, by inspection, by palpation of that particular tissue, and by locating its nature, whether it is diffuse, whether it is focal, or whether it is spreading. And how to identify the lesions. The lesions have different clinical presentations, like it may be an ulcer, it may be a fluid-filled blister, it may be flat, it may be raised from the surface, it may be mobile, it may not be mobile. So we will see the few of the clinical and few of the histologic terms which we see in any lesion of oral mucosa. Okay, whenever you see oral lesion, that is a macule, that is a papule, that is ulcer. So what actually is a macule? What actually is a papule? What actually is ulcer? We'll study the definitions basically. We'll study the histological terms. We'll study the definitions of few of the common clinical terms which we use in our routine practice. Okay. So macule. Macule basically it is a well circumscribed flat area which is of varied color, and it ranges in size from few millimeters to about 1 centimeter in diameter. Okay, about less than 1 centimeter. So if you can see the picture there, the macule, it is just a flat pain lesion, but it is well circumscribed. It is restricted to one particular area. And to remember that the macule is not raised from the surface, it is not elevated from the surface. It is just a flat pain lesion, flat plain lesion, okay, which is less than 1 centimeter in size. What is a papule? Papule is a small, well circumscribed, solid, elevated lesion which is less than 5 millimeter in diameter. So if you can see the picture there, the diagrammatic representation there, the papule is just slightly elevated from the surface. Yeah, again it is well circumscribed, it is restricted to that particular area, and it is less than 5 millimeter in diameter. Okay, that's the characteristic of a papule. What is a vesicle? Vesicle, it is again a fluid-filled blister which is well circumscribed and which is less than 5 mm in diameter. If suppose the fluid-filled blister is more than 5 millimeter in diameter, it is given the clinical term as bulla. Okay, now you can see the picture there, the diagrammatic representation there. Vesicles and bulla are both fluid-filled blisters, but the size of vesicles is very small. It's just about 5 mm in diameter. Bulla is little bit larger in size, about more than 5 mm in diameter. And we'll see many of the dermatologic diseases present the characteristic manifestations of vesicle and bulla. Okay, so you should know the term, what vesicle means, what bulla means. Okay. Then nodule. Nodules are nothing but raised lesions which are raised above the surface and which are more than 5 mm in diameter. Based on their location, based on their whether they are present located superficially or deeply, they are divided into the exophytic nodule and endophytic nodule. Okay, these are basically elevated lesions which are just raised above the surface. And what is a pustule? Pustule, as the name indicates, it is containing pus in it. Yeah, it is a well circumscribed lesion which is filled with pus and it is less than 5 millimeter in diameter. Okay, Erosion. Erosion is nothing but the break in continuity of epithelium, where the break or the whatever the discontinuity is present, it is not extending up to the underlying connective tissue surface, and even the whole of epithelium is not involved. Okay. We know the epithelium has characteristic 4 layers: stratum basale, stratum spinosum, stratum corneum. So in erosion, the break in continuity of epithelium doesn't extend to the basal layer. It is just restricted to superficial layer only. Whereas ulcer, there is a break in continuity of epithelium with resultant exposure of the connective tissue. So if you can see the diagrammatic representation there, erosion is just restricted to the superficial layer of epithelium, whereas ulcer, the break in the discontinuity of epithelium is just extending to or involving whole of the epithelium. Okay, so that the connective tissue is just exposed to the environment. We see recurrent aphthous ulcer. There's a lot of the connective tissue exudate will be just the connective tissue is exposed to the oral cavity. It shows the characteristic fibrinous exudate like that. Okay. What is the sinus? Sinus is nothing but the communication of cavity to the epithelium. Okay, suppose a blind cavity is occurring in the oral epithelium, it is just connected to the epithelial surface, and sometimes if it has pus, it is just discharged to the external surface of the skin or mucosa through that particular region. It's known as sinus formation or the sinus tract. Okay. Premalignant lesion. We know according to World Health Organization, the definition of premalignant lesion is a morphologically altered tissue in which cancer is more likely to develop than its apparently normal counterpart. That means it has significant dysplastic features, the premalignant lesion. Okay, the cells, whatever are present, they show some atypia, some cellular atypia, some changes in the nucleus, some changes in the cytoplasm. So they are beginning to show the malignant changes or the dysplastic changes. The commonest of the premalignant lesion is the leukoplakia. It has a significant risk for transformation into malignant lesion. Premalignant condition is nothing but a generalized state which is associated with significantly increased risk of developing cancer. Iron deficiency anemia. It is more commonly associated with the development of Plummer-Vinson syndrome and sideropanic dysphagia, ultimately leading to malignancy because of simple anemia like the iron deficiency anemia. Okay, and even the oral submucous fibrosis, if we see, it has more potential of developing into a carcinoma. So normally we see the lesions in oral cavity, they are either red or white in color. So what are the white lesions of oral cavity? White lesions, they denote an abnormal area of oral mucosa which appear to be whiter than the surrounding mucosa, and sometimes the surface structure may be either raised, either roughened, or there will be some difference between the white area from the normal surrounding mucosa. So the term white lesion is used for that abnormal area which is whiter in color. Okay, and the keratotic white lesions. Keratotic white lesions are nothing but the abnormal lesions of oral mucosa, the white lesions of oral mucosa which cannot be removed by scrubbing or scraping. The lichen planus is one characteristic of this keratotic white lesion. Yeah, lichen planus cannot be removed by scraping. Non-keratotic white lesions are the white lesions of oral mucosa which can be removed by scraping, like the candidal leukoplakia is present. You can just scrape the lesion and it just goes away. The candidal infection, the fungal infection more commonly, they denote the non-keratotic white lesions of oral mucosa. Hypertrophy, as we all know, hypertrophy is nothing but increase in the size of organ or tissue due to increase in the size of cell. Hypertrophy of tissues is seen. Characteristically in oral and maxillofacial region, we see the facial hemihypertrophy where one side of the face is enlarged. Hyperplasia denotes the increase in size of organ or tissue owing to increase in number of cells. So number of cells present in that particular tissue are increased, ultimately leading to enlarged size of the tissue. More commonly, we see the gingiva is enlarged due to use of any drugs or any inflammation. So that's a case of gingival hyperplasia. Hypoplasia is nothing but incomplete development of an organ or tissue. Most commonly in cases like the condylar hypoplasia, where the condyle of one side of mandible is just underdeveloped owing to maldevelopment, that denotes a hypoplasia. Aplasia is complete absence of formation of organ or tissue. In case of condyles, again sometimes it may be malformed, sometimes it may be completely absent, so that denotes aplasia. Atrophy is nothing but degeneration of the organ, that is, there is a decrease in the size of organ, ultimately leading to complete deformation. Okay, it doesn't form completely. The mutation of genes, basically they are responsible for causing the genetic disorders. The gene is the constitutional genetic makeup of the individual. Any abnormality either in the DNA structure, either in the encoding of the genes, is responsible for causing the genetic disorders. So mutation is basically a permanent change in hereditary material, that is the genetic constitution of the individual. If any alteration or the disorder of chromosome occurs, it ultimately involves a change in that particular gene and leads to mutations or inherited defects in the individual. Okay. And what is a hematoma? Hematoma is basically a tumor-like malformation seen due to excessive proliferation of one type of tissue, like the hemangioma. We have seen that hemangioma, it's a vascular malformation where the arteriovenous plexus, it was showing excessive proliferation than required and ultimately leading to the clinical manifestations of hemangioma. What is a teratoma? Teratoma is basically a true neoplasm which is made up of a number of different type of tissues which are not native to that particular region. Okay, it may be like an ectopic tumor occurring. Okay, teratomas are most commonly seen in ovaries. Choristoma is basically the microscopically normal cells occurring in different locations, like the Fordyce granule. You know, Fordyce granules, basically they are the activity of a sebaceous gland present in the skin. Suppose if the sebaceous glands, they are located in the oral cavity, mostly in the buccal mucosa, they denote normally appearance of sebaceous glands in oral mucosa is they denote a choristoma. Neoplasm, as we know, the definition of neoplasm is the abnormal mass of tissue or growth which exceeds that of normal tissue, and the growth of the abnormal mass of cells is uncoordinated, and if this growth persists in the same manner even after the stimuli which is responsible for causing the neoplasm is just removed. Okay, the abnormal mass of cells just continue to proliferate. Okay, continue to proliferate at a rapid rate. And the neoplasms may be again of two types. There is a benign neoplasms or a malignant neoplasm based on the characteristic feature of the cell. Whether it is a benign or malignant, the growth of cells occur, and though benign appear to be relatively slow growing, malignant changes, they show characteristic rapid growth, and they involve the regional lymph nodes. The metastasis is the characteristic feature of malignancy. Again, what is metastasis? Metastasis, it is a process by which the tumor spreads from one side to a distant side by involvement either through bloodstream, hematogenous, either through lymphatic routes. Okay. Hyperkeratosis. When we see the histologic appearances of few of the tumors or few of the neoplasias, we see that they show a characteristic thickening of the uppermost layer of epithelium. That is, the stratum corneum is thickened. That is nothing but hyperkeratosis. What is acanthosis? Acanthosis is the thickening of the stratum spinosum. We know epithelium has 3 or 4 layers. Uppermost is the stratum corneum, then is the stratum spinosum, then is the stratum granulosum, next is the stratum basale. So if the stratum spinosum layer is thickened or widened, it is known as acanthosis. What is acantholysis? Acantholysis is basically the separation of the cells in the stratum spinosum. We know because of the disruption in the hemidesmosomal junction, the intercellular bridges are disrupted, and the epidermal cells, they just lose their connection, they become weak, and they are just responsible for causing the intraepithelial split. So acantholysis is nothing but disruption of cells or separation of cells. And histologically we see the dysplastic features are seen. What is dysplasia? Dysplasia is nothing but irregular atypical proliferative changes in the epithelium seen in response to chronic irritation or inflammation. Basically the cell size are disrupted, there is increase in nuclear cytoplasmic ratio, there is increase in nucleoli, the number of mitotic figures may appear to be increased in number. There is some change occurring in the cellular level in the cells. Anaplasia is basically the reversal of a highly differentiated mass of cells into cells of less differentiated type. So based on the clinical terms, okay, I have discussed the common clinical terms and the common histologic terms which we use for any describing any neoplasm scene. Okay, based on the clinical appearances, based on the histological appearances, we have identified the changes occurring, and then we give a diagnosis, right? Initially, before sending the patient for any histological examination or any investigation, just on the basis of clinical examination only, you give a provisional diagnosis, right? What is a provisional diagnosis? Provisional diagnosis is the diagnosis which is given after taking history and clinical examination before carrying out any investigations. Then after taking the history and clinical examination, you send the patient for characteristic investigations. Okay. And whenever diagnosing a lesion, you have to make out a list of probable diagnosis. Okay, after making provisional diagnosis, you have to make a list of probable diagnosis. That is nothing but a differential diagnosis. It is a process of identifying a particular disease by differentiating it from the other disease processes occurring. Okay, because a lot of neoplasms in oral cavity, they have similar signs and symptoms when seen only the clinical picture. Okay, so you have to give a provisional diagnosis. You have to write a list of differential diagnoses. Okay, inflammatory conditions are present. It may be this, it may be inflammatory hyperplasia, or it may be fibrous hyperplasia. You have to just make a list of differential diagnoses like that. Then after carrying out the routine radiographic examination and other biochemical tests, at that time you will arrive the final diagnosis. And history, clinical examination, investigations, all these help us to make the correct and exact diagnosis. Okay. Then after predicting the diagnosis, you have to, after taking out the diagnosis, you have to just suggest treatment to the patient and give him indication of the disease process, the prognosis of the disease process. Okay, prognosis is nothing but the prediction of the course, duration and termination of the disease and the likelihood of its response to treatment. So you have to just give a broad idea to the patient the what disease is he's having and what are the future chances of development of this disease into malignancy, or what are the likelihood of his recurring from the disease process.